Speaker is Dr. RUSHAD SHROFF. I invite him to give his back-to-back talks on total EKR and other EKR variations which apply to different concepts in the IOL power calculation, as well as his IOL power calculation in keratoconich and ectatic eyes. Thank you.
So good morning, everyone. I'm just going to combine these two talks, and since some of the previous speakers have covered some of these concepts, I'll keep the first talk very brief. So we can skip over these particular slides. The reason why we need so many K readings is because of these eyes which are not following Gulstrand's law. So you have post-LASIK corneas which can have a wide range of curvature within the central 3 mm zone. You can have post-myopic eyes that can miss the central flatter zone and tend to overestimate the corneal power. You can have errors in ELP, as Dr. Matthew elucidated earlier. And keratometers and topographers measure only the anterior surface, and this changes after you've had a refractive surgery, as Tushar had mentioned earlier. So I'm just going to skip over the EKR because I think it was covered in detail. But as Ikeda mentioned, it's very important to look at the way the EKR is distributed. The axis is important because you have changing axes in the 4 millimeter zone, then you may have difficulty in putting a toric lens in these cases. The histogram at the bottom tells us about the distribution of the K readings, and a single peak or a higher peak is better. You can have up to 2 peaks in normal corneas. The other thing to look at is the standard deviation, which should be well within the normal range before going ahead with a toric or a premium IOL in these. Another thing to note is the pupillary diameter. When you're looking at EKR and selecting the IOL power, if the pupillary diameter is 3 or 4, go closer to those readings. If it's anything more than 4.5, stick to the 4.5 mm zone reading actually for the IOL power calculation. So this was also covered. EKR is important in keratoconus, post-refractive surgery eyes, PMD, irregular corneas, post-keratoplasty, and in eyes with a poor ocular surface. Now, the reason why I brought up true K and total K is that there is a confusion. Very senior people often also interchange these terms. True K is a formula that is used for post-refractive surgery eyes, and we have to be very, very clear on that. And total keratometry is actually something that we do when we are looking at the total, we are looking at the posterior corneal astigmatism as is measured by devices. So instead of predicted posterior corneal astigmatism, you're looking more at actually measuring it. So the TK that we refer to in the formula, the Barrett Universal 2 with the TK, is actually talking about the total K, not the true K formula. So total keratometry combines the anterior and posterior corneal surface measurement as well as corneal pachymetry. TK is designed to be equivalent to K readings and therefore can be used in standard IOL power formulas with existing constants in normal eyes, and it's designed to match the Gulstrand's ratio. So this is the Barrett toric calculator. You can see that the predicted PCA is measured and the measured PCA. You can select either of these two modes. Using total keratometry with the predicted PCA would tend to give you overcompensation of the posterior corneal astigmatism, and this is practically something that one should avoid while doing IOL power calculation for toric IOLs using this formula. So the newer Barrett formulas for the total keratometry include the Barrett TK Universal 2 for non-toric IOLs, Barrett True K with TK, which is basically for post-laser vision correction eyes, and the Barrett TK Toric for toric IOLs. So I'll move on to the IOL power calculation in keratoconic and ectatic eyes, which we'll go into a little bit more in detail. Why is IOL power calculation in keratoconus challenging? One, because it's an irregular astigmatism. There are errors in ELP estimation. There's non-alignment of the visual axis and the steepest portion of the cornea. There tends to be a hyperopic shift or an overestimation of IOL power on optical biometry. The cone location can influence outcomes, and the keratometry measurements tend to be non-repeatable. So Casey violates these rules because the refractive index of 1.3375 does not actually work in this. Like I mentioned, non-alignment of the visual axis and the steepest portion, and there's larger deviation of the ELP. The optical biometer tends to overestimate the corneal power, and therefore you get an underestimation of the target IOL power and a post-operative hyperopia. So one important thing in history to take in your keratoconich patients are they contact lens wearers? This is important because they have to be off their contact lenses. You'll have a lot more rigid lenses in these patients, so they have to be off that for about 2 to 3 weeks. Otherwise, contact lens warpage can occur. It's important to aim for a slightly myopic target, and as was mentioned, if there are contact lens wearers with scleral lenses also, it's better to avoid a toric IOL. You may change the axis of the alignment of the cylinder in these patients, and they may not accept that very well. You have to explain to the patient that a toric IOL, and this is basically an astigmatic debulking procedure. It's not something that's going to get rid of the astigmatism completely, and avoid toric IOLs in patients who are happy with the scleral lenses or their RGPs. The important thing to remember is to under-promise and over-deliver, and you have to counsel them regarding possibility of IOL exchanges or piggyback IOLs. So when do you plan a cataract surgery for a keratoconus patient? There should be a visually significant cataract, and it's very important that the keratoconus should be stable. That's important to look at on the tomography. Look at Kmax values should not deviate more than 1 diopter over a 6-month period. There should also be a relatively stable refractive error and no history of progression at that point in time. So this is a review by a paper regarding keratoconus. I'll just like to highlight a few points. The first thing that I mentioned, the keratoconus should be stable. The other thing to look at is the severity of keratoconus, and I'm going to come to that in a bit more detail because of the use of the IOL formulas depends on the severity of your keratoconus or your ectasia. Toric lenses, like I mentioned, if they're planning to use their scleral lenses or RGPs post-surgery, then maybe better to avoid a toric. Coming to choosing the right IOL formula, there are various different papers on this. Most of the traditional IOL formulas don't tend to do so well. There's a paper published in JCRS talking about the Barrett True-K formula, which does very well. The Barrett Universal with the TK also does quite well, and the Kane formula has also come into vogue for this, which actually does well. In the traditional formulas, SRKT tended to cause a little more myopic shift, and that was actually good for a keratoconus patient. So here are some examples. This is that of a 48-year-old lady with keratoconus. She had significant cataract in the left eye, which is basically of a posterior subcapsular nature. This was the tomography. The patient wanted a toric IOL. We counsel her saying that there would be some amount of residual cylinder because the IOL power we were getting was more than the highest that can be corrected with the imported lenses. And in this, when we look at the biometry sheet, what we got here was the SRKT was showing about plus 15 as the IOL power, and the Barrett TK Universal was showing about plus 14. When we repeated the measurement, as was mentioned earlier, you can see that there's a little variation. It's coming to about 14 and 13. This was what we looked at regarding the EKR report. And because the axis was relatively well matched, we decided to go ahead with a toric in this particular patient. The pros for the toric IOL were that the auto-K, the IOL master, and the pentacam axis was matching. The patient was not a contact lens user. The magnitude matched reasonably well between the three devices, and it showed consistent axis and magnitude in the central 4.5 mm zone. The cons for the toric IOL was that the IOL master 700 TK magnitude was higher than what was coming in the pentacam. The IOL power calculation, as is mentioned in keratoconus, it can be a little bit tricky. You may not be able to hit the target. And as I mentioned earlier, problems with the ELP, etc. But with all this in mind, we decided to go with a monofocal toric IOL. And we went, in this case, looking at both the SRKT and the Barrett TK universal formulas, and we went for the slightly more myopic value. This is a paper that talks about biometric prediction error, and this was a case where we had a mild to moderate keratoconus, and because the error was not very high, it's about minus 0.3 diopters, we decided to go ahead with the toric in this. And these are the various different, we fed in the auto-K values, the pentacam SIM-K values, as well as the IOL master TK values, just to